Uh, Thank you very much, Aaron. Am I on the right microphone? Cool, thank you. I'd like to introduce you to Dr. Jillann Farmer. From 2012 to 2020, can someone tell me, is Dr. Farmer on the screen? Sorry, I'll wait. No, I'm waiting for Dr. Farmer to be on the screen, I think. All right to go, hello. Hi, Dr. Farmer. From 2012 to 2020, Dr. Jillann Farmer served as the Medical Director of the United Nations, directing UN medical teams responding to some of the most challenging medical situations, including Ebola and the Zika virus, in some of the remotest locations on the planet. Dr. Farmer was also responsible for the health and well-being of some 70,000 UN peacekeepers, most of whom were local health workers, Indigenous to the remote locations within which the United Nations peacekeepers were operating. So I have a couple of questions for Dr. Farmer. First of all, though, hello.
Hello, Annabelle. Thank you so much for this invitation. Before I go any further, I missed the original acknowledgement of country, and I would just like to acknowledge the Bidjara people and pay my respects to any Aboriginal and Torres Strait Islander people present today.
Thanks, Dr. Farmer. We want remote Australians, here at RAM, we want remote Australians to step up and be part of the conversation, design and development of their future primary healthcare pathways, to have the confidence to ask the questions and drive the decisions that have to date been made about them, not with them. Could you tell us, please, about your journey from country Queensland to Director of the United Nations Medical Services in New York?
Yeah, it's quite a journey, isn't it, and quite a contrast. I spent my first night lying in New York, listening to the sirens, having left my beautiful property with acreage and wildlife in Queensland, lying there listening, thinking, oh my goodness, what have I done? But, you know, it was a journey of incremental steps of wanting to try and make the system work better for people that it didn't really seem to work terribly well for. And I started off as a rural scholarship holder back in the old days. I don't know that they still do it, but the Queensland government had a rural scholarship scheme where they would provide me with income support to finish my medical degree in exchange for a return of service obligation. And I returned my service in a few different locations. Those jobs tended to be the places that they couldn't fill with people who wanted to be there voluntarily. And whilst it felt like my wings were really clipped during that period, without any question, I learned so much, and it was that experience that was the foundation that allowed me to step in and understand the practice locations of the doctors who were working, and other health workers actually, because some of our stations were staffed by paramedics or nurses. So that initial sort of harsh baptism in my very early formative years really helped me understand those challenges. And then I worked clinically for a while, and then I started working on the safety and quality agenda, and I started seeing so many things happening where the services available and the experiences for families and patients in healthcare services remotely. The postcode lottery was really extreme. So I was working in safety and quality, and then one day I saw an ad for a job at the UN, so I applied. There was no great magic to it, no political lottery. But I do think that combination of the experience I had working in outside tertiary healthcare in Australia was one of the things that helped me get that job.
Thanks, Dr. Farmer. Going forward, remote Australians will be campaigning for remote and very remote Australians to have equitable access to a mandated minimum standard of primary health care that aligns with the standard accepted as normal in uptown inner city metro, but that is designed and developed to accommodate their particular geographic and demographic challenges and still meet each community's needs. In your experience orchestrating medical responses in some of the most isolated and variable locations on the planet, what are some of the key principles to delivering effective, sustainable responses in varying and diametrically different communities and environments?
Yeah, thanks, Annabelle. This question has really caused me to reflect back on the work that we did to achieve exactly the goal you're talking about. Make sure that personnel deployed in the most remote locations had access to care. And I'd like to just share a couple of slides with you because this is actually a very topical discussion at the moment. I don't know if any of the rest of you are United Nations junkies like I am, but there's been an enormous amount of discussion lately about a concept called universal healthcare. And Australians often stop listening when the discussion about universal healthcare kicks in internationally, because we tend to assume that because of our Medicare system, we have universal healthcare. But what I would point out to you now, I'm just trying to get my slides up. I think that you can see that now. So this is the UN's Sustainable Development Goal number 3. And this was back in 2021, my analysis of where we were at in achieving that. So this is a slide from a talk that I delivered in 2021. Premature deaths occur in the lowest socioeconomic areas, and people living in outer regional, rural and remote areas have premature death rates about 40% higher than the major cities. I'm preaching to the choir here. It's not my intent to tell you your business, but I just thought I would put that up because historically I've seen Australia ignore many of the international organisation initiatives on the assumption that we're too good for that. We're beyond that. They're not made for us. But the big dialogue happening in the days before the General Assembly meeting in New York, which is happening right now, one of the key topics was universal health coverage because it's one of the key planks of that SDG 3. And I'll give you a moment. The reason I put some slides up was so that those of you who prefer to read things can see it, because I see this concept, which is a WHO and UN endorsed concept of universal health coverage, is incredibly applicable to the challenges that you're facing, because I think it's safe to say that if Australia was honest with itself, we have not achieved universal health coverage for our remote communities. And you include reproductive, maternal, newborn, child health, infectious disease. There's a whole list there. And it's not just the provision of the services, it's about having workforce, and it's about protecting people from the financial consequences of paying for health services out of their own pockets. And I'm sure that some of you have experienced the financial impact of the patient transport subsidy scheme. I know that in Queensland, the rates of remuneration to support people to travel are just ridiculously low. And I think that they're about the order of a quarter or even less of the amount that parliamentarians and public servants are paid as a travel allowance to travel to the same locations. So that's an area of gross inequity that, as far as I am aware, continues, and a point that really needs to be addressed. So this slide is a direct lift from a program of work I did with the UN, which shows how we went about planning those services. And then my next slide, I'll show you how I think it might be applicable for you. And you can take this and morph it and do what you wish with it. It is not copyrighted, it's not special. It was just the output of some working groups that I had with doctors across the UN system. So the first thing that we did was to define the mandatory health support elements. This is this little list here. This is the list that we came up with. Now, you might have your own list. So we have to have a way of getting access to hospital level care. We need to have a mass casualty incident plan. We need to have primary care. We need a medical emergency response. We need mental health services, and we need medication, including, and this was a big topic in these duty stations, universal access to post-exposure prophylaxis. So that if people had intercourse and they were unsure if they were safe, that they could get the drugs to prevent HIV infection. So that's what we set as our minimum standards in the UN. And then on top of that, we obviously had to take account of the local conditions. You know, some duty stations would be in a place, for example, with venomous snakes, and other ones would be at altitude. Other duty stations would be at extreme heat. So we also then would look at, were there any things in the local area that contributed to heightened risk that meant we might need to look beyond the mandatory elements. So those two sides of the slide then feed in. Let me show you how I think, just thinking about your circumstances and what you're trying to achieve. So I reckon you could, communities can define your lists locally. What is it that we need? and then there's a gap analysis. And the key thing for us at the UN was not that we had to put everything in place everywhere. And I have to say, I did learn a lot from Australia in helping the UN get to this position. But, you know, the idea that you map what services must be delivered locally and what services can be dealt with by role substitution, by telehealth, or by making sure that you have a rapid and, you know, resilient Medivac system to lift and shift people when something goes wrong. And you can see here that I have put in, oh, look, that was a late last night. I've put specific, it should be specific, local risk management plans. So it's that concept, what's the minimum that every community needs? Does this community have any particular risks and particular needs? And then how do we fill those gaps with a combination of traditional services, role substitution by augmented practice from others, telehealth, Medivac, and whatever other gap-filling measures you wanted to put in place. So just thought I would share that thinking with you because it was a structured way of thinking that really helped us move forward. And I have confirmed with the UN, it's been 3 years since I left there, I have confirmed with the UN that they are still using this. It's obviously continued to evolve since I was working there because it's been a while. But that way of thinking has helped them remain in place in some incredibly difficult locations.
Thanks very much, Dr. Farmer. Unfortunately, we're on limited time because I can just feel questions in the room. However, I also know that you've made time. Could I just tell you that Dr. Farmer is doing two things at the moment. One is working for a new organisation called A Better Culture, which is a national project funded by the Commonwealth to improve the culture of healthcare in the workplace in Australia, in the health workforce, obviously. But she's also doing clinical practice, and she's about to go on duty. So, Dr. Farmer, thank you so much for making the time to join us this morning. We really appreciate it.
Great pleasure. Thank you so very much. And I'll be happy if anybody has got questions, you can collate them and send them, and I'll be very happy to answer.
We will do that. Thank you so much.
Thanks. Bye-bye.
Bye.